Thank you, Alok, for the nice presentation. And now we will have Dr. Jasim Shahid. He is consultant neonatologist and pediatrician at, in UK. I think it's in East Lancashire, isn't it? Yes.
Yeah, in Lancashire Women and Newborn Trust, East Lancashire. Yeah.
He has special interest in neonatal stimulation and is lead for that in his trust. And he is graduated from India and then subsequently moved to UK. And it is my pleasure to welcome him, and mic is to you, Jasim.
Thank you, Rajesh.
Dr. Jasim, you can share your screen.
Yeah, just give me a second. Hi. Is the talk visible? Hello.
Yeah, it is. Yeah,
Yes,
thank you, Dr. Rajesh, for the kind words. And I would like to thank Dr. Monica, Dr. Sridhar, Dr. Rajesh, and Taufik for this invitation. And thanks for all the help with the IT, Taufik. Monica actually asked me to do a talk on neonatal simulation, and she said she wanted it to be very practical. So I thought I'll use this opportunity to tell you how we used simulation in our department in East Lancashire over the last few years to implement various guidelines and to improve practice and to reinforce practice, as well as how it helped us with COVID scenarios as well. So basically what I'll be doing is in the next half an hour, 40 minutes, I'll give a brief introduction on simulation. I will tell how we use simulation to implement a new practice with a certain example of delayed cord clamping. I will also show how we use simulation to reinforce practice by designing a specific simulation course for the trainees in our hospital. We'll also, the last bit will be on how we use simulation to establish COVID protocols. So what is simulation? Simulation in healthcare can be broadly defined as a tool, device, and environment that mimics an aspect of clinical care. It is essentially imitating a real life scenario and seeing how things work and helping enhance learning in a safe environment so that both the staff and trainees are prepared to handle various different scenarios. I'm going to show you an example of a simulation of preterm resuscitation.
Look at the idea for me.
That's come off.
Okay, just fine. Put in a pre-rectal, please.
Yeah.
Can you have some hat, please?
Temperature probe on.
Okay.
Okay.
So is the baby having any spontaneous breathing at the moment?
He's beginning to breathe. He's a bit gaspy at the moment, but beginning to breathe.
So what's the heart rate, please? Can you have some heart rate, please?
So what you saw in the video is basically a simulated scenario for preterm resuscitation. So there'll be a trained facilitator to help with this kind of a scenario. So why simulate? Many people ask this question. Simulation allows teams which train separately but work together, like the nursing and medical staff who have trained in different roles. They work together to help them work together to train for high-risk, low-frequency events. They help cascade training with regards to human factors, team working, behavior, and interaction. They allow active learning processes through experiential learning, and can definitely improve outcomes if practiced effectively. So what are the different processes we can use? So we can use task training sessions. That's essentially if you want to show a new equipment, you can use task training sessions to show that equipment, skills and rules. Say you want to teach bag and mask ventilation. You can use skills and rules simulations to teach that. You can have departmental simulations with predefined scenarios. And then you can have multidisciplinary scenarios. Say you want to show how you simulate transporting a baby from one hospital to the MRI center or elsewhere. So you can have a multidisciplinary scenario which will involve many teams. Where do you do it? You can do it in a sim suite. The one I'm pointing to right now is a photo of a sim suite. You can have a departmental area converted to facilitate the sim. Like for this instance, this is Southampton's neonatal sim suite. And then you can have in situ, that is at the point of care. I'll talk about this in more detail as we go along. So how? Essentially, any simulation should have a predefined scenario, and then you have a pre-brief before the simulation where you explain what the simulation would be and what mannequins are available, what equipments are available, and how you'd go about it. And then you run the simulation session. And then at the end of the simulation session, you have a debrief. And the debriefing is done in different styles of practice. That it's a separate talk in itself. I will not go into the nitty-gritty of debriefing, but this is what a simulation would essentially entail. Mannequins, you have low fidelity mannequins, simple task trainers where you can teach bag and mask ventilation. You'll have medium fidelity mannequins like the life cast mannequins, which have realistic airways to actually show you can teach intubation and run different scenarios. And then you have high fidelity simulations where you have mannequins with heart rates, respiratory rates, and with where you can change different modalities, the baby going blue, all that can be shown. It is not necessary to have a high fidelity mannequin essentially to run a proper simulation. You can actually create enough psychological fidelity, that is reality, with the right kind of a proper simulation instructor running it with moulage. So now I'll come to how we use simulation to implement different practices. And in this particular instance, I'll talk about delayed cord clamping and how we use simulation in our unit to implement delayed cord clamping. So delayed cord clamping in extremely preterm infants is now becoming standard of care. There is conclusive evidence that DCC reduces inotrope use, the need for transfusion, the incidence of IVH, and necrotizing NEC in preterm infants. If it's used effectively, it reduces the cardiac output as well, and helps stabilize both the systemic and the cerebral pressures. And our team embarked on implementation of DCC in all gestational ages in 2018. Now, this was a new practice. Nobody had done it before. We were doing DCC in gestations about 37 weeks in term babies, but in preterm babies, we had not implemented DCC. So the aim was to make DCC a part of routine care for all births, irrespective of gestational age. So we engaged in a multidisciplinary simulation training program to achieve this. Now, how did we go about this? So previously, like I said, the resuscitation of extremely preterm babies they had immediate cord clamping and then was routinely performed at the resuscitator. We bought 2 LifeStar trolleys to facilitate DCCs. I put a picture of the LifeStar trolley here. So basically, it's a portable resuscitator that facilitates delayed cord clamping while also allowing respiration at the bedside. So this basically provides temperature control. It's a heated mattress over here. And we also have an RPAP machine, which I'll show you in further photos, which will help with respiration at the bedside. Now, this required engagement and training of all staff involved. And in the UK, we have to have at least 85% staff trained before we can embark on any new practice. So how do we go about it? We did multiple things. So first thing what we did was we had a guideline created. And based on the guideline, we started off with teaching how to use the LifeStart. So we had task training sessions. So this is essentially the LifeStart machine, what you can see over here. You saw it in the other photo as well. So where this is a suction apparatus, this is the RPAP machine with which we can give both inflation breaths as well as ventilation breaths. This gives both PIP and PEEP essentially. And this is a heated mattress. And what you see over here, the sheet over here is basically, if you want to sterilize, this is a sterilized cover, what we use when we go for resuscitations in the theater. So we taught staff in these task training sessions how to use this equipment in both birth suits and the theater, how to use the transformer and the thermoregulation apparatus in the machine, as well as how to deliver respiratory support. And this was with the help of simulated mannequins. Then we moved on to neonatal team simulation. So we had large and small group simulation sessions. We used simulated patients as well as colleagues and mannequins. Each member of the team performed their expected roles, and these scenarios were used to demonstrate local guidelines as well as contraindications when not to use it, how to go about doing it. All this was taught to the neonatal team separately in small group sessions. So there you can see one of my colleagues is actually simulating the mother, and then we have a mannequin where which is being used to show how to deliver the right amount of inflation breaths and ventilation breaths with the use of LifeStart trolley. Once we got a certain amount of engagement from our neonatal team, we then moved on to obstetrics, anesthesia, and theater staff. So the plan was to cascade training to everybody who would be involved in DCC in the trust. And so then we went to the labor suit. So you can have, this is the midwife actually delivering. We have a Lucina doll, a mannequin, which the obstetrics team used. So we got that through, we got engagement from the team there. And here we are practicing a simulation with the LifeStart trolley and DCC in real time. One of the good things which came out of this session was we were able to fine tune our guidelines as well. We kind of understood that we needed say in this scenario, in this labor room, we actually didn't have extra oxygen concentrator. So we needed a split oxygen concentrator and air port valve as well. So we arranged that. So we went into each of these labor suits and tried simulations to see what equipments are necessary and what ergonomics need to be changed to help facilitate this. After the labor suits, we moved on to the theater. So here you can see a full section happening. But again, this is a simulated section. You have a Lucina doll over there, and you have the DCC trolley being shown there. And we ran the session. I'm just showing you different photos on how we ran the session about. So here you can see that the baby has just been delivered by a cesarean section. So that's a simulated mannequin, which is being put into a neo-wrap bag and then moving on to the resuscitator. And here you can see how they're giving the CPAP or ventilation breaths if required using simulation. This is a full picture. The cord is still intact, and we are basically giving respiratory support to the baby at the bedside. Here the cord has been cut and clamped after physiological thing. So we generally do it for 1 minute and more if the baby allows it. And then once the cord is cut and clamped, you move the trolley from here back to the resuscitator. So following multiple task training sessions for a period of 4 months, we hit the 85% target. Concurrently, the departmental simulation team also ran it for the neonatal team, which was going on. And over this period, we implemented DCC in clinical practice by those who were already trained. Deliveries were supervised by consultants who were both proficient in the guideline as well as the use of the LifeStart trolley. And like I said before, using the feedback, we rearrange the ergonomics of the department. We fine-tuned the guidelines, and from late 2018, we have been doing DCC, and things have been going without a hitch till COVID hit. But even now, we're practicing DCC in all babies. So that is DCC and how we implement DCC. The next bit is how we use simulation to reinforce practice. So we have a unique problem in the UK. I think might not be unique in the UK. It will be in any training hospital where you have trainees rotating every 6 months. We have 2 levels of trainees, the junior doctors who rotate around 4 months, and we have the senior tier who rotate every 6 months. Now, Though generalized resuscitation practice are standardized, there are variations in practices among different units. For instance, some places use the Portex ET tube, some places use the Vigon ET tube. The clamps used to connect these ET tubes might be different in different places. Some places suture ET tubes on, some places use the NeoFit or the NeoBar clamps. And trainees who have just worked in one unit might not be used to all these different practices. The other thing is the levels of experience of the trainees will be different. Their acumen will be different at different levels, and all of them might not be trained equally in every aspect of neonatal resuscitation and emergency care. Consultants are on call during out of hours, and they have to drive in 10 minutes to 30 minutes drive time on where they live, based on where they live. So the middle grade trainees can sometimes be faced with these emergency scenarios where app management will determine outcome. So we had a think tank of around prenatal consultants and took feedback from colleagues, other consultant colleagues as well. And we thought we would do a bespoke simulation course in our unit for in-house medical and nursing staff to address standardized practice by all team members in preterm and term resuscitations, ensure that all trainees are trained in using the LifeStart for delayed cord clamping and servo control in preterm management. Like I said, LifeStart is not used in all units in the country. Some units are still starting to use it. Some units do delayed cord clamping with the help of resistor. Some units are using the Concord vent as well, Concord machine as well. So it's different practices in different units. So we wanted to ensure that all trainees who start with us are trained in using the LifeStart. We also incorporated pneumothorax and difficulty with training during resuscitation. We wanted them to handle unexpected surgical scenarios, which can happen as a non-surgical level 3 unit. So we don't, essentially all surgical cases are transferred across to the surgical center antenatally. Now, at times you have mothers walking in with a gastroschisis or a diaphragmatic hernia and delivering. So we wanted our trainees to take care of these babies as well as address human factor training in various resuscitation scenarios. So what did we do? We created a resuscitation interest group with 3 consultant facilitators leading this group. And then we devised a 1-day simulation study course, which included high frequency, high risk, that is common events, and low frequency, high risk scenarios as well. So extreme preterm resuscitation of a baby with a pneumothorax, resuscitation and stabilization of unexpected surgical scenarios, which included gastroschisis and congenital diaphragmatic hernia, and resuscitation of a baby with no cardiac output. Each course was designed to have 8 participants and run every 8 weeks. We had 1 middle grade doctor, 1 Tier 1 doctor, or an advanced neonatal nurse practitioner, 1 senior nurse, and 1 junior nurse or a midwife as part of 1 team. And so we had 2 teams running, being trained in every course. We started this around in early 2019, and we have had around 7 study days so far. There was a miss of a couple of study days because of COVID, but then we have now continued with adequate safety practices. So the initial courses, we gave brief lectures followed by sims, which involved a pre-brief, simulation, and debrief using the advocacy inquiry or debriefing with good judgment technique. After that, we obtained feedback after the first couple of courses, and the trainees told us that they wanted LifeStart. They wanted to know how to use the LifeStart. They wanted also to understand how to use a video laryngoscope. They wanted separate task training sessions on insertion of a chest train and servo control and preterm resuscitation. So then we started in the future courses, we started having task training sessions for these procedures as well. So here you can see one of my colleagues actually training trainees on how to use the video laryngoscope. You can see the video laryngoscope here and how they are using it. So what we did after the feedback was that we started running all the scenarios twice. So during the first attempt, the facilitators used something called rapid sequence deliberate practice with start-stop session. So the session will start, and then if we feel that something needs to be addressed, we stop it there. We then give them a directive debrief or a feedback on how things went, how things could be done differently, and then we restart that session from the start. So they kind of got multiple small sessions during and the whole scenario. And the second attempt was the same scenario run in its entirety. And then we finished that off with an advocacy and query debrief. So this is after COVID started, one of the courses where we are doing debriefing. You can see me there and my colleague who are facilitators, along with the participants, running a full advocacy and query debrief at the end. We've had a lot of positive feedback from the course, from the trainees. We looked at the average confidence levels. Pre-course was around 6.1 out of 10, and the post-course we got trainees ranked their confidence levels at 9.2 out of 10. This is a word out of all the feedback we got from the trainees, and you can see that good and useful being the most common words being used. So the key message from what we did and how we did the NRIC courses, you have different courses, but then a bespoke course to train both rotating and permanent staff in advanced resuscitation scenarios in a standalone unit is feasible. And this will enhance confidence among both staff members, especially consultants who are on call at home, and invariably improve neonatal outcomes. And then, how did we use simulation to get our way around or still going through the pandemic? So the COVID dilemma. COVID hit us in March in the UK. I think it hit different countries at different points of time, but we faced the brunt and all the challenges was started off around mid-March. So what did it bring along? It brought in change. It brought in the virus, as well as it brought in change in usual practice. We had to create a framework for practice. We had to implement that framework, and we had to ensure that it was safe when we were implementing things. Now, and all this had to be done at breakneck speed. So how did we go about it? What are the changes in practice? So we had to receive the baby in a separate area from the mother. Life start had to be deferred. Resuscitation needed to be done with full PPE. Use of a dedicated transport incubator for moving suspected babies, and the more senior staff to attend to reduce exposure, and less number of staff to attend high-risk scenarios compared to previous when you had many people helping out. So at that point of time in March, there were not too many guidelines, or there were no previous guidelines at all. The British Association of Perinatal Medicine started off with some webinars on basically how to go about dealing with these babies being born to suspected or positive COVID mothers. And they brought out some resources as well. The NICE got out some guidelines. The Public Health England also gave some guidance on how to don and doff. There were guidelines coming out of the European Research Council as well. So what we did was we identified key personnel. We nominated a COVID guideline lead. We had a nominated PPE advice lead, because things kept changing. When to use the right PPE, in which scenario use what? Is this process, or is high flow aerosol generating procedure? Half the people didn't know. So we got a nominated PPE advice lead to help fine tune and streamline that. We got a nominated nursing team lead who specifically dealt with COVID scenarios. We then had multiple MDT meetings with anesthetic, obstetric, and theater staff. And guidelines were then quickly created with the available evidence, which the guidelines incorporated multiple clinical scenarios. I think there were around 8 or 9. It also had scenarios on how to don and doff. There were lots of flowcharts and diagrams on how to go about it. And the social distancing policy in all areas were predefined. We also created a task force and had regular meetings. The consultant and senior nursing team had regular meetings to see how we're progressing with stuff as well. So once we got the guideline ready, then the dilemma was, how do we test this guideline? How do we and once we have the guideline in, how do we percolate this guideline to the staff quickly and effectively? Things kept changing at rapid pace, and keeping the staff informed and informing them was a challenge. And then, would we be able to run simulations? How would we go about it? So again, the implementation dilemma. Do we do in situ simulations? Do we do otherwise? Do we run it in a sim suite? Can the in-situ simulations be done? How do we go about it? So what are in-situ simulations? I briefly touched about previously, but these are simulations run at point of care. They're excellent for evaluation of systems and processes, but can be disruptive to the area of work. Now, we were not very sure whether we can use in-situ simulations or not, but we went ahead. So we created, the major scenarios we created were these 4: COVID research scenario in the theater, a COVID research scenario in the birth suit, a postnatal collapse scenario, and a dope scenario in COVID isolation room. We got multidisciplinary involvement with the neonatal consultants, nurse educators, ops consultants, midwives, theater managers, and postnatal matrons being involved. As a consultant body and nurse educator team, we ran a trial first to see how all these 4 different scenarios worked. And then we looked at the learning points, and there were a huge number of learning points. We understood in-situ simulation can work. We thought that PPE is the stumbling block, but we kind of went around it. We also understood traditional debriefing, because these scenarios are long. You have to, it starts off from a crash call from a crash call going off saying that there's a COVID baby being delivered, and then it goes all the way up to the theater or the birth suit, and then the scenario happens there and then finishes off, and then all the way the baby is moved down into the isolation room. So these scenarios are long. So traditional debriefing, we thought, we understood is not working. And there were a huge number of learning points. So outcomes from the trial run: who do we need to train? We'll need to train all staff attending the COVID scenarios. What do we use? Do we use high fidelity, low fidelity? We understood high fidelity mannequins are difficult to use, so low fidelity mannequins were planned to be used. There was this question of when do we start? Do we start straight away, or do we address all the issues before you go? We thought we need to start straight away and then address issues as we go along. So how did we go about it? We went on with in-situ simulations. Each scenario was broken down into micro sessions. And then we had a mix of stop, start, stop, restart sessions. This experience helped us change our style of running the NRIC course as well, which I talked about previously. We had modified rapid cycle deliberate practice with directive feedback. I'll talk about that on the next slide. And at the end of the whole scenario, we had a very short 5-minute advocacy inquiry debrief at the end. So what is rapid cycle deliberate practice? Essentially, you are a novice performer. You run a session, and you're given a brief feedback. Then you become competent. Again, the session is rerun, and you're given a brief feedback. You become proficient. Again, a session is run. You give a brief feedback, and then you become a master. Once you become a master, you increase the level of difficulty, and then you still, if the level of difficulty is increased to a level, to a certain level, you might become a novice again. So this is what is called rapid cycle deliberate practice, and it has come a lot into resuscitation debriefing nowadays and simulations. So the sims, we ran multiple in-situ simulation sessions. We covered 72 staff in the first few weeks. Learning sim points from every sim was collated and sent to the sim lead. That was me. Sim action matrix was created and updated on a daily basis. Now, what is a sim action matrix? This is something which I'm proud of. What we did is we created a sim date. We created issues identified and say this is a sample where we say trolley beds were in corridor. So we had to talk to the theater in charge who had to sort that out. So we put an action plan in place. We arranged somebody to undertake that action and put their name involved. And we saw every day how things were being resolved and new things being cropped up. So this is still ongoing. So in summary, if you are running a scenario or if you're creating new practices, you have to establish a clear plan, get the wider team involved. If it's a new practice, always have a trial run before you start running it. In-situ simulations work well to establish guideline change. And for those people who are already simulation instructors, try exploring different debriefing styles. Thank you. I'll leave you with a photo which came out from a unit and which went viral around the world. Some of you might have seen it. Thank you.
Hello. Thank you very much, Dr. Jassim Shahab, for that very interesting lecture. And really, it is a very good effort that is for COVID pregnant mother. And really, I feel that the world will be before COVID and after COVID, because that is NRB 2020. There is they are stressed on delayed cord clamping for term and preterm babies, but here in COVID we are missed this delayed cord clamping. I attend a very interesting lecture from Dr. Monica about briefly what is the NRB, but in 2020, but everything is changed with COVID really. Yeah, after we are NRB with an American Heart Association, they are putting recommendation in 2020 about the new NRB. The algorithm is the same, but there's some recommendation like use of the ECG and epinephrine IV and stop resuscitation after 20 minutes. But they are stressed on the ventilation. Even the routine suctioning of the oropharynx, they are not recommended right now. Yeah. Even if there is meconium stent liker, they are not recommended for that. So after I hearing your lecture, so everything is a change in my mind before and after COVID. But really, it is very interesting lecture, and we appreciate your effort during this COVID time. This is my. We will make the questions after the last lecture. Again, we will introduce our eminent speaker, Dr. Alok Sharma. He's again is a consultant neonatologist in the Prince Anne Hospital, Southampton, United Kingdom, and he will speak about the very interesting lecture. Cannot intubate, cannot ventilate at 25 weeks. In the new NRB also they ask that you can resuscitate without you are having tube. They said yes with bag and mask, but Dr. Alok, I think he will explain to us how we can deal with a baby with 25 weeks with difficult intubation. So the floor for you, Dr. Alok. Thank you very much.
That's very kind. Can you hear me and can you see my presentation?
Yeah.
That's great. Fantastic. So I am going to talk to you. I'm going to contextualize my previous talk on management of the difficult neonatal airway by actually talking about how you would manage babies where you have difficulty with ventilation and intubation when they're preterm. And for this part of the talk, which will take me about 20 minutes, I'm going to talk about this difficulty in extremely preterm babies and how you manage that particular situation. So just to give you a little bit of an idea, this is a baby that's delivering at about 24 weeks of gestation. And clearly, what we know is when these babies deliver, they are extremely small, extremely immature. Their airways are extremely friable and at very high risk. The majority of these babies, I would say, about 70% of them are known to breathe well at birth, provided they're not perinatally asphyxiated or have other risk factors. But a lot of them will need, despite their abilities to breathe, support with breathing. And what you can see here is one of my esteemed colleagues giving a baby some inflation breaths in order to support its breathing while the nurses are applying some saturations. Now, clearly from our perspective, the challenge in this particular situation when the baby is this small is twofold. A, we need to effectively aerate, ventilate, and expand the lungs. But B, a lot of these babies at some point might even need to be intubated for the purposes of surfactant. And in very small babies, with people as they're gaining experience, they can have difficulties both with mask ventilation and with intubation, as you can see in this particular baby, where they had difficulty actually trying to mask ventilate the baby. So actually decided that they would try and intubate the baby. Now, what you can clearly see at this particular point is that my colleague has got the baby's head in neutral position. We're using quite a large size mask. We now have 00 masks available, which we can use for babies as small as 400 grams. But that's really important. Having a good seal is very important. More importantly, from our perspective, you can see how difficult it is because the baby's being handled. So are we actually effectively ventilating, somebody keeping an eye on chest wall movement? What you can clearly see is the heart rate's not rising with these ventilation maneuvers, and the baby's saturations are actually dropping. So the team actually is unable to move the baby's chest, hence they decide to go for intubation in this particular circumstance. Now, when we have difficulty intubating any baby, the classical concept that we've been taken through, which is part of the neonatal resuscitation protocol, is MR SOPA. And what we need to make sure is that we're using an appropriate size mask, that mask is effectively applied to the baby's face, that you have good seal, that you're not overextending, that you've got the baby's head in neutral position, because that compromises your ability to get a good seal. But there are some very simple things that some people sometimes forget. So a baby who's about 500 or 600 grams at 25 weeks of gestation has a very small stomach. And when you continue to do IPPV for a period of time, often what you might find is that you inflate the baby's stomach with air. That inflation actually splints the diaphragms, and you're very quickly in a situation where you can't continue ventilating these babies. A simple maneuver, passing an NG down in those circumstances and getting somebody to decompress, will greatly help your abilities to be able to ventilate that baby. What is very important also is that we often are advised to start with pressures of 20 to 25/5. In my setup, we start in 30% FiO2, and we start with pressures of 20. We give 5 inflation breaths. These are 3-second inflation breaths, which is slightly different to how the NRP actually performs their ventilation inflation strategy. But these are babies with very stiff lungs. We might not be using enough pressure, hence we might not be moving the chest. So we might have to put those pressures up gradually to about 25, repeat another set of inflation breaths. And some of these babies, from our perspective, as I've described, so with the NRP, you tend to use what we call ventilation breaths. But in our setup in neonates, we use the neonatal life support protocol. And the recommendation there is to actually use 3-second inflation breaths. So some babies will obviously need higher I times. The most important aspect of managing to ventilate babies is making sure that you're not failing due to human factors. And human factors basically means that we might have any of these things that is a problem. We haven't recognized them, but they're easily correctable. And actually, if we can recognize that by passing a nasogastric tube, we can decompress the stomach, that is something that's easily correctable. And by doing all of these things, we will ameliorate our difficulties with ventilation. But it might be that this preterm baby has a genuine anatomical problem, which is causing an issue. It might have airway obstruction due to secretions. It might be, and we know that preterm babies have quite large tongues. They tend to have glossoptosis, and it might just be that while we're actually providing these breaths, we're using very high pressures. We're using very high pressure on the face. And what we now know is that the trigeminal neuralgic reflex gets stimulated, and some of these babies often develop glottic obstruction. So it's really important that we're not using such a high seal pressure on their face that that's actually causing pain. Once that happens, they develop glossoptosis, and a mixture of both of these problems, would necessitate us going through MR SOPA again, but sometimes an inability to actually inflate these babies' chests. What we must also recognize is that some preterm babies born as early as that may have rupture of membranes for an extended period of time. So I've recently managed a baby with rupture of membranes from 13 weeks, where we found it extremely difficult to actually ventilate this baby's chest without actually increasing pressures. And what classically these babies present with is hypoplastic lungs. Occasionally, some babies, during the process of providing inflation ventilation breaths, their lungs will pop. And if they develop bilateral tension pneumothoraces, that air will accumulate in the pleural space and will make ventilation virtually impossible. Some babies, when you intubate and ventilate them at later stage, have severe chronic lung disease and need very high pressure. But in the delivery suite, these are some of the reasons that you might have difficulty trying to ventilate and move the chest wall by establishing an FRC in babies who you're mask ventilating in delivery suite. Now, not unexpectedly, a lot of our colleagues would actually get into trying to intubate these babies if they're having difficulties with mask ventilation, if the baby has significant respiratory distress syndrome, if the baby's chest is very stiff in order to give surfactant. But one of the questions that I want to emphasize to you about management of preterm babies is that these babies can be mask ventilated effectively. You can put a nasogastric tube down, and if they're breathing spontaneously and you're having difficulty intubating them, you can actually use non-invasive ventilation strategies to manage these babies until you get them into a better situation. That means that you can use CPAP if they're breathing spontaneously. We can deliver CPAP and delivery suite using the mask. You can also, in your setup, if you have facilities, be able to actually transfer the baby on CPAP and use CPAP on high flow to humidify the baby, allow it to spontaneously breathe with PEEP to actually recruit the lungs. And that means that for you, you will be able to establish the baby's breathing and FRC and effectively ventilate this baby while you're trying to establish whether this baby really needs intubation or not. And if this baby needs intubation, it's then kind of deciding what it is that you're going to change about your failed intubation attempt in delivery suite to be able to enable you to intubate the small baby. Now, preterm babies can be difficult to intubate for a variety of reasons. There might be a buildup of secretions. You might have loads. Even suction catheters might not be enough in situations where you have florid secretions. You might need a large bore suction catheter with high suction to clear them. Some of these babies sometimes have vocal cord spasm, but a not uncommonly encountered situation is a situation where you have been trying to intubate a baby repeatedly, and the preterm baby, as you know, the airways are very fragile and very small, and they go on to develop glottic edema. Now, that is a very, very difficult situation to manage, and I will give you my experience of managing a situation like that in a 25-weeker. But the one thing in this situation is that when the baby is small, you can't use an LMA or an iGel if you're failing to intubate, because actually they're too large. So how does video laryngoscopy help? So I'm going to show you some videos. So this is a video of a baby that you can see who's about 27 weeks of gestation. And what you can see is that this baby is being intubated using a video laryngoscope. And you can see how secretions obscure your view, but you've got a partial view over here. So what this baby really needs is good cricoid pressure, because the tube is actually slipping behind. So because I know this baby needs cricoid pressure, I'm going to give cricoid now. So what you can see, the tube is slipping behind, but with a little bit more cricoid. Can you see how the airway becomes better, more prominent? And can you see how repeated failed attempts at intubation actually cause trauma to this airway? So what we need to do in situations like that is, a person has had numerous attempts. We probably need a fresh person to be intubating this baby. So you bail out and you get the most experienced person who's going to manage the airway. So we're continuing IPPV in these circumstances, and we're having a fresh attempt at intubation. And you can see how secretions are a problem here, but good cricoid pressure as delivered here. And the tube goes through without any problems. So what is important is that we've used the concept that I've spoken to you about before, which is the human factors approach. And what it talks about is why you're failing. And in this baby, clearly, we had attempts at intubation where a trainee had tried and another senior trainee was trying with the video laryngoscope. But clearly, we weren't giving enough cricoid. The airway was more anterior. And by giving good cricoid and having an experienced person intubating this baby, you could actually pass the tube down without any problems. Now, this is another baby. This is not a preterm baby, but this is a term baby where I'm using a video laryngoscope, where a trainee has had difficulty intubating. And what you can see is this baby's breathing. So we're not using drugs in this baby. You can see the glottis moving. You can see how the baby's moving. You can see the cheek here moving. And that's the glottis with the vocal cords. And a trainee is having an attempt at intubation. Can you see how the tube's not going through? Now, because this baby's light and we're not using sedation and paralysis, this baby's actually got vocal cord spasm. So actually in this situation, what we need to do is we need to stop intubating this baby, go back to doing IPPV. And in this situation, what we did was we stopped the intubation, we bailed out, we gave the baby some intubation drugs, as you can see over here, in order to allow the baby to relax. This was a sedative and a paralytic agent. And then we had a fresh attempt at intubation, again, a very experienced clinician who's intubating a baby who's now completely sedated and paralyzed. So the vocal cords are also paralyzed and the tube goes through without any problems. So again, we're following a concept, which means we're changing what we're doing based on what we see and how the baby is and why we failed the first time around. Now, if you continuously intubate a baby, what eventually happens is these babies develop glottic edema. And this is a baby preterm at 26 weeks of gestation who's developed glottic edema. And the classical manifestations are secretions. So the baby has severe secretions. But what you can see is you've developed quite significant swelling of the glottis. And with that swelling, can you see how the tube, this is a 2.5 tube, and it's not easy to get in. But you can't see any vocal cords. And what this needs is it needs the tube to be eased in very slowly, and it finally goes in. Now, we're quite lucky, but to give you a little bit of an idea, this was a situation where a baby had had repeated attempts at intubation and had developed glottic edema. And we stopped intubating this baby. We used sedation paralysis, but we also gave this baby some dexamethasone in order to reduce the airway edema. And then it was a very experienced consultant who finally had this attempt at intubation with a size 2.5 tube, which was the appropriate size tube. I think the common thing that you see with all these videos is in extremely small babies, the use of airway adjuncts like LMAs and iGels is very difficult. But the use of a video laryngoscope clarifies very clearly exactly what the problem might be, which then means that you can adapt what you're doing with the next attempt at intubation to provide the best attempt at trying to get this baby's airway secure. So all through a video laryngoscope, something that's not easily available. But if you have a baby who you can't intubate and you can't ventilate at 25 weeks, you can't use an LMA or an iGel. It's too large. You can't call ENT. The smallest scope that we have in our setup is a 2.2 fiber optic scope. So theoretically, you can get a 2.5 tube around that. But the question is, how do you get that scope into the baby's airway? What you can use in those situations is a video laryngoscope. And we use this quite frequently, mainly as a difficult airway backup, but are now training our trainees to start using this routinely. In our setup, what kind of video laryngoscopes do we have? So we have two video laryngoscopes. We've got the CMAC, which you can see on the right-hand side, and the kaleidoscope, which is an anterior airway device, which I use specifically for babies who have Pear-Robin syndrome, because it allows intubation looking at the screen with a special device that allows you to curve the tube at right angles. So actually, rather than having to intubate by direct vision, you can look at the screen and intubate. I think the advantage of using these techniques is you can actually see what's happening at the level of the glottis. But even if your trainee is having an attempt at intubation, you can see exactly what they're doing. The one thing to be aware about is the blades are quite different to the normal Miller blades that you use. So these are the CMAC blades. And while they're like Miller blades, they are very broad. And the actual space that you have to pass the tube is much smaller. So sometimes in situations, I mean, I would say almost invariably, I have to get somebody to pull the upper lip up when I'm using the CMAC in order to actually optimize my view. What I've become very good now is just looking at the screen and intubating. But you can also see the slight difference in size. So this is a blade that's 0, that's a 1. And the CMAC blades is slightly larger, but the smallest CMAC blade that I have, which is the equivalent of a 0. So there's no 00 size for the blades that you can use. So using a CMAC, I can intubate babies as small as 500 grams at this particular point. Now, besides a preterm baby, if you remember, we spoke in my last talk about babies who have broad tongues, babies with Beckwith-Wiedemann syndrome, babies who have trisomy 21, where the tongue is quite floppy, very broad, and these babies are at risk of glossoptosis. But in those babies, getting the tongue out of the way sometimes needs a blade that's much broader than a Miller. And what we use is the Seward, and you can see how broad it is. But the advantage of using the Seward is it takes the entire tongue out of the equation, which kind of means it improves your view. You have Sewards, which are straight, and this is a straight Seward. But in preterm babies, what you can't use is an LMA or an iGel. Now, some of my colleagues, and I put these photographs in just in the last 5 minutes, asked me what an iGel is. So an iGel is a supraglottic device. It's a device that you can put into the mouth of the baby, which does not go into the tracheal opening via the glottis. It sits at the glottis, and using this, it covers the glottis so that you can effectively ventilate the baby. Now, this is a baby who is preterm, about 30 weeks of gestation. And what they're using is they're successfully using a laryngeal mask airway here. But in this baby over here, who's even smaller, they're actually using an iGel. Now, just because a lot of people who are attending this lecture have asked me, how preterm does a baby need to be for you to use an iGel or an LMA? So the recommendations are that it should not be used in babies under 34 weeks. And experience says that actually for babies under 2 kilos, it will be challenging to use. I have used an iGel in a baby as small as 1.4 kilograms. Now, what I would say is that you have to be very careful, because when you use an iGel in a non-licensed way in a preterm baby, often what you'll find is this area of the iGel will curve back upon itself. So if you're using the iGel in those circumstances and you can't move the chest, you should abandon that procedure and go back to mask ventilation and organize for somebody very experienced to be intubating that baby. Alternatively, if you have a video laryngoscope, I would say that's a much better option in situations like this. Personally, myself, I have never used an iGel in a baby smaller than 1.4 kilograms. And I would not routinely use it for babies under 34 weeks and 2 kilos unless my back was to the wall. I haven't had to use it in that situation frequently, just one baby once. Now, the question is, if you have situations where you need to use difficult airway adjuncts like a video laryngoscope, like an iGel or a broad blade, how do you choose when to use what? So what we've done is, after the British Airway of Perinatal Medicine produced its guidance, it talked about using an ABCD pathway to manage neonatal difficult airways. And we've adapted that so that we have everything to be able to intubate a baby, but everything to manage a baby who we can't intubate in the first attempt. That might simply mean mask ventilation with a nasogastric tube. Alternatively, if this baby has a Pierre Robin and is breathing, the question I always ask my trainees to ask themselves is, do I need to intubate this baby now? Is there another method by which I can intubate this baby? A. B, do I need to intubate the baby at all? Can I actually manage this baby just with mask ventilation? But if this baby is a Pierre Robin with an anterior airway, what about just putting an oropharyngeal or a Goodell in, putting the baby prone, and putting this baby into sufficient oxygen to be able to oxygenate? What about using a nasopharyngeal airway? These are all devices that can actually help you while you're deciding whether your baby really needs intubation or not. On the other hand, if you have a baby with microstomia or micrograthia, you can use an oropharyngeal airway or a nasopharyngeal airway. If you have a baby with macroglossia, you can use a broad blade. Now, we've adapted these strategies and put them into an airway pathway, which talks about what to do if you fail your intubation, how to call for help before you decide to manage your baby, and what airway techniques you can use other than intubation to manage the airway while help is on its way. In the end, our facility does have the ability to be able to use a video laryngoscope. But for people who can't use a video laryngoscope, they can very much use a boogie, or they can use a supraglottic airway. So for the experienced user, they can use a video laryngoscope, but for those who can't, they can actually default to using an LMA or an iGel. Eventually, I'd say there's some babies who have structural problems and they will need to have ENT do a fiber optic intubation. And we have adapted the protocol so that we are escalating to get those people if we need it. More importantly, what you've got to do is design your airway trolleys so that the equipment in your airway trolleys is there. And we have duplicated this pathway into A, B, C, and D so that the equipment for each pathway is actually kept in each part of the trolley. We have 000 blades for babies under 500 grams. They're kept in A. So if I've got a baby under 500 grams, the nurses know that we need to take a 000 blade, because actually a 00 might be too large even for the smallest of babies. This is what they look like. And what you can see is in draw B, we've got the different kinds of blades, including the 000. In draw C, for the anterior airway, we've got iGels. But for ENT, we've got everything for a tracheostomy in draw D if we need to provide a surgical airway. This is what the video laryngoscope looks like. it needs to be cleaned very carefully. And a lot of people obviously struggle because it's quite an expensive device. So the Storz video laryngoscope costs about £6,500. And if you buy the blades, they're an extra, I think, 2,000. These blades obviously need to be autoclaved. And the question is, if you have one video laryngoscope and your blades are being autoclaved or cleaned, then what do you do? So there is a new cleaning system, which is called Crystal, which has been invented, with which you can actually clean blades before and after use. So once you've cleaned your blades, you can actually reuse them ASAP and reuse them within 4 hours. But if you were to keep a video laryngoscope and want to use it in an emergency setting, and you've not used it for 24 hours, you would need to cleanse them using the Crystal wipes. The entire process takes about 90 seconds to 2 minutes. Very easy to do. So I've used these even in emergency settings. This is the view that you get. It's a really nice high definition view of the larynx that you can see. This is a 28-week baby that we're intubating at this particular point. So that's cricoid pressure. Tube slipping. Okay. So I've come back out. So I'm just getting more cricoid. And the tube goes in. So I can't emphasize enough how useful video laryngoscopy is in trying to intubate even the smallest of babies. The smallest baby that I've intubated with a video laryngoscope is 510 grams. You get a clear high definition view. You can see what your trainees are doing, but more importantly, you can see what is happening at the level of the glottis. In summary, what I'd say is every setup can develop a difficult airway pathway for their setup. You do not need high-tech equipment. A simple device like an RMA or an iGel, where you're having difficulty intubating, can help with babies above 2 kilos and 34 weeks of gestation. Obviously, if you have the ability and the facility to be able to buy one, having one type of video laryngoscope, which could either be the CMAC, could be the Storz CMAC, or it could be the Kaleidoscope, or could be the Inspiration video laryngoscope. So there are 3 in the market. There's quite a cheap version which is available from Israel with disposable blades as well. But you can see how that really helps when you have difficulties with management of the difficult neonatal airway. The key thing is being able to use this to be able to produce a pathway which you're then able to duplicate into an airway trolley, so that everybody knows where the equipment's kept, what you use, and in which circumstances. But more importantly, the pathway also talks about how you escalate for help in managing the difficult neonatal airway. In summary, if I have a baby who I can't intubate at 25 weeks and I'm having difficulty ventilating, my recommendation would be stick to the basics. Go back to MR SOPA. Can you mask ventilate this baby? If you can't mask ventilate this baby, has this baby got an inflated stomach? Put an nasogastric tube down, decompress the stomach. If the baby's breathing, well, what about using CPAP or high flow to keep the baby breathing while you decide how you're going to manage the airway? And in those situations, what I'd say is it's really important that you've got good mask seal if you're giving IPPV, that you've got neutral position, and that you're sticking to the basics, and that if a further attempt at intubation is planned, that you are providing the most experienced provider with the opportunity to intubate that baby, that you're not allowing repeated failed attempts at intubation by a single person. Thank you very much.
Thank you very much, Professor Alok. It's very interesting, very interesting lecture, and really we appreciate. And it is I think everybody will teach a lot from your lecture. So we can take some questions, please.
Yeah. Thank you, Dr. Sharif. Alok, I would like to start, first of all, congratulate both of you to such a lovely presentation. And we have some questions from the audiences. So I'll begin with the first one. There is a question which is from one of our audiences, which says that, what about the hypoxic insult in cases needing tracheostomy while waiting for the ENT or pediatric surgeon?
That's a beautiful question. So I will be very honest and frank to say that there are babies who, say, for example, have structural airway problems and they are very difficult to manage and they will have quite severe hypoxic ischemic injury. I think what you've got to be able to do is judge how you've resuscitated that baby. And a good example is we've recently had a baby who's had an airway problem where we've been unable to get a tube down. We've been unable, from our perspective, to actually get an LMA or an IGL down because the baby's mouth was very small. But clearly, from our perspective, that was recognized after the first intubation attempt. So we avoided further attempts at intubation, just mask ventilated that baby in 50% oxygen. We could keep that baby saturating throughout, and we were able to call ENT. Now, that baby saturated and was breathing. It did not have any evidence of problems with either bradycardia or a low heart rate. So we were able to organize a fiber optic intubation for that baby. Now, that is very different from another baby who we managed with tracheal atresia. We couldn't do anything. We could not inflate that baby's chest. And in that situation, while we called ENT, when ENT arrived, it was not appropriate because 30 minutes down the line, giving that baby a tracheostomy after it's had extensive resuscitation, while it's got no heart rate, is not in the baby's best interests. So what I would say is, I would not be gung-ho about this. I would not be giving a surgical airway to each and every baby. I think you have to assess your abilities in the circumstance. And I would say to you that even in our district general hospitals, there are babies who will have severe hypoxic ischemic injury, and they do not have the facilities to be able to do and manage these babies with a surgical airway. It's inevitable that these babies will die. I think the most important thing is you do things with the best of your ability and keeping in mind you try your best. There are some babies that will die despite this, despite your best efforts. So it's considering each individual baby based on its circumstances.
I think that that's a very honest answer, and probably completely agree with you because we recently faced ourselves, probably 2 years back, we had similar case with tracheal agenesis, and despite everyone attempting, nobody could intubate. And we didn't call the ENT. We decided to let the baby go.
I think that's happened to the majority of the babies I've managed in that situation. Unless they've had a fistula where you can bag the baby, I'll be really honest. We've managed 4. All 4 of them have died.
I think, and the other thing which you mentioned about the kaleidoscope, we have tried kaleidoscopy. We are in process of getting. We have already ordered it, but we had a trial run for almost 6 months, and it is really, really helpful and very useful tool equipment to have it.
Especially for the anterior airway, the definition is very good. Gives you a very good view, but more importantly, what I'd say is the hand-eye coordination and learning it is absolutely crucial. For me, the learning curve was about 6 months, and I used to use it in elective settings first, because actually using it in an emergency on an awake baby, I found really challenging. So it does take a little bit of time to get used to it.
Just to add, we've got both the CMAC, so the new blades and CMAC. The CMAC, which has been brought out in the recent past, in the last couple of years, or last 1 year maybe, has newer blades where the camera is at the end of the blade, closer to the end of the blade. So that kind of makes it easier to use. Though they are size 0 blades, they make it easier to use in smaller babies. You also have a company called Accutronic InfenView. They have 00 blades, size 00 blades, which is pretty good to intubate the really preterm babies. We've just bought that as well. The problem with both is that one is like a laptop, so you need to have a space to keep that, and it is not easily portable. The CMAC is also bringing out a portable version, which I tried very recently. They have a screen on top of the blade. So when you're holding the handle like this, you have the screen coming up over here. The problem with that is the screen makes it very heavy. So you kind of don't have control over your hold of the blade. So it is mainly useful in adults, I guess. In our population, it becomes very difficult to use that machine as well.
Just there's a question that one of the audience members has asked on the use of supraglottic airways and delivery of surfactant. And I must say that there's an absolutely beautiful video that's been filmed by Dr. Kaushal, actually providing surfactant using that method. it's so just to say it is perfectly reasonable and a mechanism by which surfactant can be delivered. I know that the guys in Glasgow are actually using it and have successfully been able to use an LMA for administration of surfactant in quite a few babies. What I would say is obviously the recommendation for use of LMAs and iGels is for babies over 2 kilos and over 34 weeks. And that is where there might be limitations in that it's going to be very tricky to use them in smaller babies. You know, in particular, I'd say babies under 1.5 kilograms. So it's definitely doable and usable. And you know, I must congratulate my colleagues, including Dr. Kaushal, an absolutely amazing video on the use of salsa, which is available for people to have a look at.
I think the smaller ones are coming up where the last PAL, when we had attended, I saw people using the smaller LMAs as well to deliver for smaller babies. So I think it's still coming up. Yeah.
So the Europeans have produced a smaller variety of an LMA, which you can even pass an nasogastric tube down. So just an awareness, an iGel and an LMA in a neonate at the moment, as they currently are manufactured, at least in the UK, do not allow you to pass an nasogastric tube down. So there will always be an element of gastric insufflation, not very severe, that happens when you're providing them. But the Europeans have now produced a size smaller, which you can actually put a size 5 nasogastric tube down, which allows decompression as well. So hopefully, you know, in due course, we'll be able to get hold of that.
And for boogie intubation, so for people who try boogie intubation, it's always advisable that they simulate boogie intubations quite a lot before they actually go into go in and do a boogie intubation, even for an elective tube change, just because the number of case reports with respect to pneumothorax following boogie intubations are quite high. So it's always advisable that you simulate and practice it quite a few times, and then maybe try it on elective tube changes before you kind of, you know, if you face in an emergency scenario to do a boogie intubation, it will not be as easy as it looks.
There's one question, please. I want to also ask the same question. They said explain a little bit about sedation, because I observed some of the our colleagues, they insist to make sedation before intubation, but I don't know. What is your opinion about that?
So I'm going to be really honest to say I have lost my equipoise in that I am very pro using a sedative and a paralytic agent where time permits. I think the use of a short-acting paralytic is what I would recommend. I think there's a risk if you give a long-acting paralytic where the baby stops breathing, which you can't reverse, and you take away the baby's drive and then you can't intubate the baby, then you're in real trouble. So in our setup, what we've developed is we've got pre-made intubation drugs. So pre-made intubation drugs are CVAs, which consist of succinylcholine, fentanyl, and atropine. They come in a sachet and we use a dose banding. It means that we can administer intubation drugs within as quickly as 3 minutes. I would agree that there will be emergency situations which preclude the use of these drugs because it's more important to be securing the airway, and that there is a lot of problem when you have to draw these drugs up. It takes a very long period of time. And I think you have to judge what is safe in your setup. What I would agree is that there's no doubt in my mind that when you intubate any baby who's awake, it's painful, it's uncomfortable. These babies have high blood pressures. We've just done and finished a study on 120 babies where we've used pre-made intubation drugs. And, you know, if you're looking at the babies who have emergency intubation with arterial lines, their blood pressures go up, they become tachycardic. You know, there are failed attempts at intubation because of infant vigor and them fighting. It's easier for trainees to intubate if you're using pre-made intubation drugs with sedation paralysis. I think the clinical bottom line for me is if time permits, I would always use them. If time does not permit, it's an emergency. Or if I think that those intubation drugs are going to compromise the baby, maybe a baby with very low blood pressure, I might decide not to use, say, a paralytic agent. I might just use fentanyl for pain. So it's judicious use, but I would say that you need to have a good discussion with your local setup, with your nurses, with your colleagues, and agree a protocol for their use. I think intermittent use makes people more confused about what to do.
Thank you very much. There is another question. What is the smallest age of the resuscitation? For how many weeks you can start? 23 or less?
Okay, so that's a beautiful question. We're running an ethics module in which I've got Sridhar and Monica speaking to us on this, and there's a huge obviously variation in practice based on where you are and which country you're in. What I would say is that in our setup, we would not routinely offer resuscitation under 22 weeks of gestation. We do offer resuscitation above 22 weeks, and I'm going to be very honest to say that we are very circumspect at 22 weeks. So, you know, if I have a 22 plus 5 week girl who I can give steroids to, who's good sized, then my counseling to the parents, if they want resuscitation, is to help and give her a go. But obviously, if she's kind of in a situation where after my attempt at resuscitation, she's not doing well, we would probably move towards comfort care and we'd try to have those discussions with the parents. I think more or less default resuscitation for us is 24 weeks and above. I think 22 to 23 weeks, we're still having extensive discussion with the parents, and parental choice is very important at that gestation. In terms of getting tubes down, I mean, just to give you an idea, I've had a long chat with our Japanese colleagues. They're intubating babies as small as 300 grams. I'm going to be honest, I have not intubated anything under 410 grams. So, but you know, our Japanese colleagues are doing it. How they're doing it, I'm keen to learn from them. So they will be talking to us as part of our module, and we'll be looking at how they manage these babies.
Okay, there's another question. During the time we are trying to intubate the newborn, should we only ventilate with a mask bag?
What I'd say is pre-oxygenation and pre-medication where possible is important. I think what you're trying to do is create enough of a reserve of oxygen to be able to sustain the baby while it's apneic and during your intubation attempt. People talk about term babies needing 3 minutes of pre-oxygenation and 100% oxygen. I think what is really important is it's the judgment of monitoring. So if you've got monitoring on the right hand, using preductal saturations, it's achieving 91 to 95% in preterm babies. It's achieving 95% and above in term babies, and ensuring that you've achieved that before your intubation attempt. Now, that may mean pre-oxygenation for a minute in some babies, but for some babies, it might mean that you have to give IPPV for much longer periods of time. But if a baby's breathing and is saturating, you don't have to give IPPV. You can just give blow by oxygen by the mask. Let that baby breathe. And that's less traumatic to the baby. What I'd say is if a baby's fighting you and you're trying to give IPPV, just be aware that, especially for preterm babies, some of them will have an exaggerated trigeminal neuralgic reflex and they'll develop glottic obstruction. And that can become more difficult to manage. So if it's not breathing, yes. But if the baby's breathing, simply providing oxygen by mask is more than sufficient.
Another question, can you
Another
use
question.
for Cervanta administration, can you use the laryngeal mask?
So I'm going to be really honest. Should we let Dr. Kaushal answer that? Because she's just recently done it. And, you know, I think her credibility, I'm going to be really honest to say, I've never used an LMA to actually give surfactant. So I'm going to let her answer that question.
Yeah, we had to use it because we had a Beckwith-Whitman syndrome, and when the baby was born, it was such a huge tongue, and we really failed to intubate. And actually, I thought we are more traumatizing the baby rather than helping when we are trying again and again doing it. Hence, we actually ventilated the baby with LMA for 2 days.
Amazing.
And it was quite successful, and we gave surfactant through the LMA. Though, to be honest, there was a bit of spilling, and we had to use 2 doses, and one was not sufficient. But we could do it, and at least we could get away from invasive intubation, and we could just ventilate with LMA just because we could give surfactant. And if anybody is really interested, it's a YouTube. We prepared that, and I thought it would be helpful. for people to see like live, because it was a baby and we took permission from the parents to help others to learn from it. So, I mean, you can go through that video to learn more, but yeah, I'm saying it wasn't very easy. There was spilling of the surfactant, and so you have to be very careful when you're doing it.
So Callum Ferguson and colleagues in Australia are running a randomized control trial with use of the smaller LMAs that Dr. Kaushal has described. They are recruiting babies above 1,250 grams. So, you know, maybe with due course, as technology gets more advanced, we're able to get the smaller LMAs, things will become easier.
Yeah, another question, Alok, is from one of our audiences, that if you are saying that LMAs are better in difficult intubation scenarios, then why don't we use them as routinely instead of bag and mask ventilation?
So I'm going to be really honest to say there are 3 articles being published by O'Shea, a colleague in Glasgow, which is asking exactly the same question. And I can also say that there are hospitals in the UK who are recommending that midwives should keep them as part of their resuscitation for home births, because actually they can't intubate, but putting an LMA and an IGL in is quite an easy and a simple procedure. I think where I stand on that is I think you've got to decide when you're resuscitating the baby whether mask ventilation is effective. If it's ineffective, I'm in no doubt that if you need an airway to establish ventilation because the lungs are a problem, that is to deliver pressure, to deliver surfactant, or you want to deliver oxygenation effectively, then an endotracheal tube would be able to deliver pressures. The problem with using an LMA, you can't deliver pressures above 22 to 24, even with the cuffed LMAs. The other problem with obviously using an LMA is it's a temporizing measure. I mean, you can't ventilate, and I've ventilated a baby on transport with it. But I think if you really want to manage the lungs effectively, bad meconium aspiration, bad RDS, really establishing an established airway with a tube is important. I think for situations where you just need to ventilate the baby, HIE, or say, for example, you have a baby where you can't get a tube in, and you're using this as a temporizing measure, that is, I would say, perfectly acceptable. And I think in due course, I would not be surprised if with more experience and trainees using it, that becomes the norm, is the word I'm going to use. Maybe that's a little bit extreme, but you know, I think we need to be using it more often. A good way to practice it, and this is for my colleagues, my trainees out there, is if you want to learn how to use an LMA, there are some beautiful videos on YouTube. I'll be sending you the links. But for babies who have HIE, who are recovering, who are very poor with their breathing, they're ideal babies where you can, rather than intubate the baby, use an LMA to gain the experience of using an LMA to give them IPPV until such time as you have recovered them. Because a lot of babies have just got mild hypoxia ischemia. They're recovering, their breathing comes back, and you don't actually have to intubate them for long periods. But these are also babies where if you intubate them, they can often become profoundly hypocarbic. So, you know, that's a group of babies where I would say that you can gain experience. And once you get more experienced at using them, if you're struggling with intubation, then yes, I would strongly recommend that you have a supraglottic airway, either an LMA or an IGL as part of your difficult airway pathway.
I think that is also very important to understand. Remember that this is just a temporary measure, and people should not become complacent with the use of LMAs that, okay, I can put an LMA and ventilate.
Yeah.
So call for help, and early call for help is what they should be remembering.
Just one more important point on this. So a lot of adult studies have looked at use of end-tidal and capnography, which changes color with the use of LMA and IGLs. Can I say that there's only one randomized trial in neonates which has looked at it, which says that they do change color, but the change in color is not a marker of effective ventilation. So they might be changing color, you might be shifting air, but you might not be effectively moving that baby's chest. And that is absolutely crucial. This baby must improve, the heart rate must improve, you should move the chest, the sat should improve. If that's not working, go back to mask ventilation.
Absolutely.
I want to ask one question for Dr. Jason, please, if you allow me.
Yeah, please.
For COVID patients, if the mother having COVID positive and she is there now for termination by C-section, I think for the SARS-CoV-2, it cannot be transferred through the placenta. It is only droplet or something. So the baby, it will be at high risk if later on mother, she will allow breastfeed because it is not transferred by the breastfeed. But for the personnel in the theaters, so everybody will be scared. The anesthetist and even the pediatrician or neonatologist, I mean. So what is your recommendation in this scenario? If
So for a definitely positive COVID mother, we are writing a systematic review on all COVID positive patients as of 2020, and we've only had evidence of 23 cases which have definitive transmission for which we think might be intrauterine transmission of COVID. So of the 220 cases which have been roughly published based on total number of cases which have had COVID. So in suspected mothers or in definitely positive COVID mothers, previously, maybe a couple of months ago, we were getting the baby outside. So our team will be scrubbed with the full PPE on, with the FFP3 mask and full PPE on, and the baby will be coming out. The midwife will put the baby in a bassinet, move the baby out. The baby will be moved to a separate area for resuscitation, if resuscitation is required. If resuscitation is not required, though the team will still be waiting out, if the resuscitation is not required, they'll give the baby back and continue normal care along with the mother. Now in preterm deliveries or preterm, and we're having quite a few as of like the last month, we're kind of getting quite a few COVID suspected scenarios. What we have decided now is, and the anesthetists also have decided, is before everybody used to stand out, wear full PPE and go in. Now what they do is once they, in a section where they have to do a GA section, once they intubate the mother and they give a 2-minute breakout time. And once that is done, then we all move in. And then we resuscitate the baby at the bedside. And we have decided that we'll continue with delayed clamping as well, with full PPE on now, because what they say is that once you have the 2-minute breakout time and the intubation is over, the chances of aerosolization are much lesser.
Yeah, just we because our hospital is designated for COVID mothers who are being delivered. We also do the same, but from the beginning, it's been that we resuscitate them next in theater itself with full PPE. And it's the senior most person or the very experienced specialist tries to go in so that we don't expose many personnels.
Yeah, so we have the senior most registrar and the senior most nurse going in. Generally, you'll have a junior SHO along with the whole team, as well as a junior nurse and another midwife to scribe. Now you'll just have 2 people in full PPE standing resuscitating the baby with 2 people as runners and backups. So we have 2 teams. So in the morning, every day, we designate 2 teams. One is team 1, which will be the senior most person and the senior most nurse. Their names will be already designated. So in case there's a positive COVID, they run for the COVID sections. And the team 2 will take the transport incubator along with them, but they will not be in full PPE. They won't wear the full FFP3 mask. They wear the FFP2 mask and the pinnies, and they will wait outside to handle the transport of this baby. So what happens is that once the baby, say a preterm 25-weeker is being delivered, once the baby is stabilized, intubated, and put on the transport incubator, the person, the senior most person who was resuscitating the child will doff, take out all his PPE, and then read on again, because our theaters and delivery suites are 1 floor above. So he will read on again with full PPE just in case there is a tube displacement in the lift or something, and then bring the baby down.
But it will be not transmitted by secretion. I mean, it is, if we are touching the secretion of the baby or amniotic fluids or something, it will not be transmitted.
They are wearing full PPE anyway, so the chances of transmission are low. But they are wearing the full PPE. 1, 2 is that we have said any COVID suspected or COVID positive cases, they wear the full PPE. So no taking chances.
So Jasim, you are doing delayed cord clamping, that means?
Now we have restarted delay. So we had deferred in COVID suspected and COVID positive mothers, we had deferred it for the initial few months or till a few months ago. But then now that we have things have changed, protocols have changed, we have
Yeah.
restarted doing it.
And Rajesh, because I think what Hafiz had, he had one of his COVID positive mothers data he had released, and what that time I don't think so they were doing delayed cord clamping. So are you guys started doing it, or it's
No,
not?
we haven't started yet. Again,
Okay.
COVID.
Okay.
So for term babies, it was happening anyways. So if they're inside,
Even if the COVID.
yeah, the midwives were doing what they would normally do, because because our whole research team is outside the area. So the midwives what they would normally do, they would normally do in full PPE.
Yeah, if there is no high risk patient, just a normal delivery with COVID mother,
yeah,
then they do the normal things as Jasim said.
Yeah. And in preterm babies, we kind of deferred it till a couple of months ago, and now we have decided that we'll go back full and like not to actually say that COVID baby patients should have a different care compared to non-COVID patients. Also the number of suspected COVIDs also have kind of increased comparatively compared to the initial period as well.
Yeah.
So any patient with fever is suspected COVID till we have the reports back. But nowadays we have rapid COVID test swabs, which they can report back in half an hour's time. So all and we have 4-hour rapid testing as well. So all COVID patients, suspected COVID patients, and in-house patients are tested. We also had a baby which had the meconium aspiration syndrome with a COVID positive, and this was in the early time. So the lungs, we are still not sure. Actually, we're writing that case up. We are still not very sure whether it was COVID pneumonitis or whether it was meconium aspiration which caused all the problems of the baby.
So I have a question as well. Very nice talks from both of you, very practically useful. And we have all faced situations. I mean, now with the Insure and the LISA techniques coming up, one of the applications we had the CMAX and the new model which you described, we had as well with the zero blade. I totally agree with you. It's a little difficult to handle it. I mean, and as Alok rightly pointed out, the orientation is not easy. So you do need practice a few times on the dummy. And when you're live, you have to really focus on where you're going in, and the old instinct of looking in does happen. So you're actually missing looking through the video. We tried using it with the feeding tube for Lisa, and if you put it through the groove of the CMAC, it goes right to the airway. So if you're able to keep it in position, we can use it. And we didn't use it on many babies, but this practical application is one thing if you're considering investing, especially Rajesh was mentioning. So if you're considering investing, I definitely encourage that. And I don't know, Alok, if you saw the results of the poll. I think 59% had said 2 attempts. So what's your thought?
So what I would say is the question is a trick question. So the question as it's asked talks about intubation in attempts. I want to take you away from that concept. I want my trainees to think about why they failed, what they're going to do next, and what they can get in between. It's called the Q3 approach. So the Q3 approach is one that's been recently published by the British Association of Perinatal Medicine. What they've emphasized is that rather than thinking about number of attempts, once you failed your first attempt at intubation, you should think about the reasons for failure of that attempt, anything that you can do to correct that, and what you're going to do differently. But a rough guesstimate, and our literature would say that an experienced provider, you should not have more than 2 attempts of intubation by the same person. The risk is fixation. And the other risk is obviously for people as experienced as ourselves, we sometimes bring our egos into this. And that's not good for the baby. You know, in an honest environment, I'm going to be really honest to say, I've had difficulty intubating a 25-week or 18 months back. And I've got a trainee who's very, very experienced. And I had 3 attempts. And I said, fine, let's give him the chance. And he intubated in the first attempt. So sometimes in situations like that, you have to default to letting a fresh pair of eyes have a look. But rather than thinking about the number of attempts, what I would say is you failed your attempt. Why have you failed? What are you going to change about your next attempt? And really, do you need to intubate babies is the other question. You know, is there something else you can use in the interim? And, you know, for babies with Pierre Robin in particular, I'm going to be really honest to say, I've not had to intubate a baby with Pierre-Robin for the last 2 years now, because we've used humidified high flow in the delivery suite. We can get them to adapt. We can actually use nasopharyngeal tubes where they struggle. So actually, the real question that you have to ask in those babies is, do I need to tube?
We have slightly moved to a new kind of way where we say that the most experienced person in extreme preterm babies, the most experienced person goes for the intubation. You don't give it to the junior trainee to learn in extreme preterm baby. So this is just to optimize intubation. We've seen there have been instances when junior trainees have tried, not got it, and the second attempt the senior trainee gets it in. But we thought that to optimize intubation, the best way forward would be to give the most senior person there in these babies the best chance to get the tube in. So we have, in our unit, we have advanced neonatal nurse practitioners as well who have years of experience and they intubate almost anything as well. So sometimes they go ahead and do the tubing.
I don't know if you attended the lecture by Professor Jonathan Stein on 22-23 vehicles in Iowa. So he said they have a separate team just for these babies.
Yeah.
Once they go below 26 weeks, only the most experienced people handle them from day one till they're taken to be stable. So it's a very sensible approach.
Yeah.
And Dr. Sharif's question about pre-medication, it's a very important one. And having worked in both setups, when I was in UK, we were very used to this. And actually, Chris Lilly in Glasgow was the first one who thought of this pack of pre-medication stuff, which is very handy and everyone is using it. But after moving here, when I've seen people who are stable in jobs, we don't have trainees anymore. We have only the senior people intubating. One of the negatives of pre-medication was obviously the bradycardia episodes we used to get. I mean, the fentanyl-related chest wall rigidity, difficulty bagging. The period you bag the baby is much more when you're using pre-medication. And when you're having a slick intubator, you oxygenate if needed, as you said, to 90 to 95%. You don't need to pre-oxygenate with 100% knowing the toxicity of oxygen.
Yep.
And then you go in without pre-medication fairly quickly. Mostly 1 or 2 attempts at the most. There is not much trauma as we would visualize. So it's experience of the intubator that matters. And in UK, because the trainees are having a look, and we also get used to that concept. So even we are used to pre-medicating. And when we do it ourselves without pre-medicating, it's actually easier because the laryngospasm that you said, the medication also has a contributing effect to that. So in our unit now, because we have a stable team, we don't have trainees, everyone is only improving with intubation skills, which is already good. So we don't use pre-medication except for the most difficult cases. And just one point, I think, about the, what was I about to say? Sorry, you carry on. It's fine. I forgot the point.
I think, I don't know, Dr. Alok, because we don't, as we trained, we never did pre-medication. And when I had gone for 3 months to UK and I saw that pre-medication thing, sometimes being followed and sometimes not followed even there. What Sridhar said, because we feel that we have done it very easily, but I don't know what happens physiologically, even in that once attempt to the baby, like as he said, the baby becomes tachycardic and the blood pressure shoots up if we don't do it, pre-medicate them. So I'm not sure. I don't do it myself, but I'm not sure whether we are right, even if I have done it quickly, not pre-medicating those babies.
But the other point we have to consider is the damage to the lungs by bagging for a while, or the bradycardia episodes. If you need chest compression, for example, even briefly, it's not going to be beneficial for the baby. So it's a balance of.
That's what I'm saying. Like, what would be the?
I think what we have done is we have divided into two. When it's an elective intubation, we always use pre-meds. If it's a semi-emergency, again, we try to get medications before we intubate. But as you know, in UAE, unfortunately, we cannot get MRN numbers before the baby is born.
Yep.
Cannot get medications before the baby has MRN. So if it's a delivery room intubation, it's almost 100% without pre-meds.
Yep.
Because we cannot get the medications.
No, you can have emergency medication, Rajesh.
Yeah, but not in our setup. We can only get it if the MRN is there. If the baby does not have medication number, then we cannot get it. So in delivery room, generally we get it, but we generally intubate them without pre-meds in delivery room. But it's an emergency situation. And again, as you were mentioning, if it's needing a cardiac compression, I don't think anybody will wait for pre-medication.
No, absolutely.
Yeah.
I think very fair points that, all my senior colleagues have kind of alluded to. And I think I do agree with one aspect of what Sridhar and Rajesh sir are saying, is that what we want to try and do is not take the baby's drive away for a very long time, because the risk in that situation is we then consign them to the need for ventilation. And, with Lisa coming in, as well as with the ability to be able to give surfactant that by that method, actually the need to ventilate these babies is less and less. I think we had a huge debate on whether we should be using sedation with Lisa recently on Twitter. And, again, there are two schools of thought, because we don't use sedation with Lisa at all. I just use atropine. And the reason and my thinking there is I don't want to take the baby's drive away at all, especially the more preterm they are. But there's some of my colleagues who believe that's, that we should. And I think what we really need is a good randomized control trial, which actually looks at our ability to be able to measure pain, to be able to demonstrate the efficacy of these drugs with good follow-up of long-term neurological outcomes. And I think that's lacking.
So I remembered what I was about to say. I know you run the advanced or difficult airway course. So I mean, one of the useful tips that the NRP textbook gives you is to hold the tube horizontally, so you're not hiding by the tube going in.
Yep.
So that is something that the trainee should remember. And the neck position that people keep, sometimes if you overextend it, the larynx goes very high. Yep. And the angle is not achievable. So in addition to the cricoid pressure, I mean, you have to keep the neck in a as straight line as possible, a little shoulder roll, but not too high. And don't overextend, because we tend to overextend. The overextending is not good for the IVH risk as well. So do you have any tips like this which you would like to tell, especially for the extreme preterm intubations? And have you ever tried finger intubation?
Never ever done or tried finger intubation. So any kind of blind approach to trying to intubate any baby is fraught with risk. There's also a risk of trauma to the airway. So I've never done it. I've read about it, but never done it. I think what I would say is I completely agree with you on overextension. We have some lovely videos, and I will supply Tawfiq with the links to them, which actually show with a video laryngoscope what happens when you overextend and how you compromise your view. And what is really helpful is if you've got another person watching you and you're failing due to that reason, they can actually tell you that you're overextending, because sometimes you're so fixated and so close to the baby, you don't realize that you're overextending with your actual process. So that is very important. The other thing that I would say with extremely preterm babies is with the video laryngoscope in particular, some tips. So preloading, as you described, very useful. So preloading means that you can actually take your endotracheal tube and keep it right at the tip of the video laryngoscope, but you'd be using the screen to intubate. And the other thing that I found quite useful is having a nasogastric tube down. It delineates where the esophagus is. So especially for trainees, when we're trying to train them to differentiate the glottis from the esophagus, the ability to be able to visualize the nasogastric tube going down the esophagus then is a good marker that that's the esophagus, and actually the glottis should be anterior to that, especially when they're using the pullback approach. So, I completely agree with you. A shoulder roll, again, very, very useful in circumstances like that. And the other thing I would say is obviously making sure that you're using the right blade size for the right baby. So, for extremely small preterm babies, I would default to using a 00 blade under 700 grams routinely, because I just find you have more space to be able to put the tube in. On the other hand, I would say that, for bigger term babies, above 3 kilos, you really want to use a size 1 rather than a 0 size laryngoscope. So you're right. All of those aspects are very important.
We have actually moved on to
Question for Jasim.
Yep.
Criteria for diagnosis of positive, like really, what is your criteria when you say newborn is positive, COVID positive? And are you using aerosol box for COVID deliveries?
No, we're not using aerosol box for COVID deliveries because the babies were coming out till recently. So we're not using the aerosol box. And if you're actually trying to intubate using the aerosol box or a screen in front, it kind of makes it even more difficult. So we have the shield on. So one of the interesting things we learned from simulation when we were simulating during the the start of the COVID pandemic was that I remember one of my trainees telling me he had this shield on. He's telling me that I can't see anything, I can't see anything, I can't intubate. So we took out the shield, and the shield actually had a film on it, which he had forgotten to take out. So that is why he couldn't see anything. So these were things which we learned with the simulation during the COVID pandemic. Now, our criteria to say that the baby there is the intrauterine transfer is if we feel that if the rapid test of the mother is positive, and the baby also we do a rapid test and it becomes positive, then we would think, and if the baby is having symptoms as well, then we would definitely say that there is a possibility of intrauterine transfer. So if you have rapid COVID positive baby and rapid screen positive for mom as well. We are also following up all the babies of these positive mothers as well in clinic, just to see that they are all fine over here. And the few of them I have seen are all okay. So, like I said, there are only 23 cases reported in English publications around the world who might be a possible intrauterine transmission of COVID. And again, all the papers, they don't have definitive criteria. They have used vague criteria from what we are writing up now.
You had some comment about the previous question.
I think I lost my flow of thought. It was about the video laryngoscope, isn't it? So the tips, you asked for tips. So one of the tips I have is if you're going for less than 24-week intubation, a small baby, 350 gram or a 400 gram, and you need to use a size 2 ET tube. Most of the times what we try to put introducer into the size 2 to intubate these babies. Now the normal introducer we have over here, I'm sure that will be the same make in almost every resuscitation unit. They won't go through the size 2 tube. They're too tight. They won't go through the size 2 tube. So it has a film on top of it. You'll have to strip that film off so that the introducer goes through the size 2 tube. So that's something which people have to bear in mind when trying to resuscitate these babies. Also, the smaller babies, we have kind of said that we'll be using a triple lumen UVC. So the standard instead of the double lumen UVC, we are looking at using triple lumen UVCs for the smaller babies for resuscitation. We've had 2 22-weekers which have come through after the BAPM guidelines have changed. Their parents wanted full resuscitation, and we are learning with every 22-weeker.
I think because of the constraint of time, we'll have to stop our session here. Though it's such an interesting kind of a presentation, and you guys really helped me out, like making it so practical. And actually, we got the answers of the nitty-gritty of small things which we face in every day when we are managing these kind of babies. And so Dr. Alok, Dr. Jasim, Dr. Sharif, Rajesh, Sridhar, thanks everyone. And Tawfiq, thank you very much for making this.
Thank you, Tawfiq.
Yeah.
Thank you,
so
Tawfiq.
very IT, all nitty-gritties were well managed. And thanks, and hope to see you all again. Thank you.
Thank you for the opportunity. Thanks
All
for
the audiences as well.
Yeah, thanks, audience. Yeah, of course.
Yeah, thank you very much to all. Before close, just comment about the CME points. So the program is accredited with 2 CME points. So tomorrow you will be receiving one form for the survey of the program. Once you fill it, you will receive it to your email, the certificates. And Dr. Alok has promised like some videos and slides also. So I will be sending to all the attendees through email that one as well. Okay. Thank you very much once again. Until we see next time. Thank you.
Thank you.
Have a good night.
Bye-bye, friends. And you.